Okay. Well, welcome to our question and answer session for this week, folks. This is our the opportunity that we have to have what I call the father of silver fluoride joining us today for our question and answer session. So, worldwide father of silver fluoride, and we're really happy that you've decided to come along and join us for our Q&A and present a case history. So what I'm going to do now, Graham, is I'm going to bring up that share screen and we're going to give that a go.
Okay.
We are going to do here.
Just by way of background, this is a case, very interesting case done at the Montefiore Aged Care Home in Sydney. This patient was in his 80s. He had dementia. He had a number of quite serious medical conditions. He was taking a heap of medications, and he presented a real treatment problem because he'd only sit in the chair for a very short period of time, and he would only allow the operator to touch the actual tooth, but not the gingiva. Wouldn't allow anything near the gingiva. Now, if we can go to the second slide, let's have a look at the situation that presented. Thanks, Kathy. Okay, if we look at the lower left slide here, you will see that the patient was managing to chew quite well on a full upper denture and a lower denture, which was supported by roots of remaining teeth. Now, if we go to the top right slide, when the lower denture was taken out, this is what one saw. It wasn't a very pretty sight at all. Now, the problem being to extract those teeth, the chances of doing it in the chair were about the square root of nil. And the operator was faced with the do we give this patient with all his medical problems a general anaesthetic? How do we handle the situation? Now, the experts away from the area said, oh, take the teeth out. Okay, well, the operator said, no, this is not practical. This is not feasible. So he'd been using silver fluoride followed by status fluoride for some time, and he said, look, nothing to lose, we'll give it a go. Now, if we look at the lower right slide, that is the appearance of the teeth once he had applied the silver fluoride, and he could only apply it to the root surfaces. He applied silver fluoride, left it there for, I think, I'm not quite sure it was 1 to 3 minutes, but it was in that gap, and then applied the status fluoride, and that's what it looked like. That's the you can see the reaction between the stannous fluoride and the silver fluoride. All the silver ions have been reduced to metallic silver, and that's the appearance that resulted. And if we go to the next slide, Kathy. There we go. Right, now, this series is actually quite fascinating. That was, on the top left, that was the appearance 4.5 months later. Things are starting to improve a bit. Then go to the upper right slide, 1 year and 1 month later, not too bad, not too bad. And he was still, the point I got to make, he was still chewing quite happily on his full upper and the lower denture supported by these tooth roots. Then, now this is another interesting thing. For some reason, at 1.5 years afterwards, this is the lower slide, he started to get gingival overgrowth, which you can see there. Now, the operator was faced. Now, what do we do from here on in? Anyhow, at 1.5 years, he gave the patient another application of silver fluoride followed by status fluoride. I must point out that from the very outset, the operator was applying the silver fluoride, status fluoride every 3 to 4 months. Anyhow, the lower slide shows the picture 1 year, 6 months. And if we go to the next slide, is it? Okay.
Mm-hmm.
Now, look at some changes that were starting to take place. Nothing had been done except just these regular applications every 3 to 4 months. At 2 years, just over 2.5 years, 2 years, 7 months, this is the situation. Look how healthy the gingiva are. The gingival tissues are, I should say. Then, notice at 3 years, 1 month, in a mouth with minimal saliva, look what was happening. We had a formation of calculus. Now, there was something in this application of the silver fluoride followed by stannous fluoride that for some reason, with a patient with such impaired salivary flow, it was dragging the calcium and phosphate out of the saliva and depositing it as calculus. Now, this is quite, at this stage, we literally couldn't believe what one was seeing. Anyhow, if we go to the next slide, thanks, Kathy. Right, now have a look at the situation 3 years and 10 months later. It is truly remarkable. That was hard, it was firm. The patient had had two teeth removed, and by sheer luck, the operator was able to take them out of the chair. The reason being that the patient's daughter, who is a medico, came along and told her father to sit still, allowed the dentist to give the injection. You had to stay still, Dad, and the dentist was able to give an injection and take out the premolar, the lower left canine premolar, which was a bit of a problem. But the point is that these remaining root stumps were there supporting the denture, and the gingiva around them were healthy. The patient was happy, and that has continued on. And the top right slide shows the situation at 4 years and 4 months. Now, by any reckoning, this has been a remarkable transformation. And if one has a look at the lower left slide, just a reminder of what one started out with. Now, the beauty of this is that it was all done in the dental chair. There was no need for a general anaesthetic. The patient continued to wear the upper and lower denture. The chances of this patient wearing, if those root stumps had been taken out and a new full lower denture made, the chances of him wearing it were negligible, quite frankly. Anyhow, it was a very, very satisfactory result and quite a very, very interesting one. And Alan Deutsch himself published this result in Special Care Dentistry, which is a refereed scientific journal, and the referees were quite intrigued. We got some very interesting comments as a result of it. So look, that's the case from start to finish over a period of 4 years and 4 months. But it shows it shows a very interesting potential of the use of the silver fluoride followed by stannous fluoride. Now, if anyone has any questions, I'm only too happy to answer them. And any other questions on silver fluoride followed by stannous fluoride? See, I've been involved with it for 1 or 2 years now.
Those you should tell them that those most of those treatments had to be done outside in the sunshine because that patient was most relaxed out there.
Yeah. Well, as I say, look, the patient really did have some tremendous problems. I'm not a psychologist, no training in psychology, but it was an interesting form of dementia that only allowed certain things to be done to him, etc. So anyhow, a very, very satisfactory end result.
Mm-hmm. Okay, so there's a question here. Was there any reapplication of silver fluoride, during the course of that care for the patient?
Yes, every 3 to 4 months there was a reapplication. Remember this patient, there was no oral hygiene, zero oral hygiene. He would not allow a toothbrush anywhere near his mouth. And so this was all done by applying the solutions to actually those root stubs. And if the operator deviated onto a gingival tissue, there was an untoward response.
Okay, and looks like Kate's got one.
I was just going to say, fantastic result. Thank you very much. Sorry I'm late starting. We had fire evacuation, but
Right.
but yeah, fantastic result. Kath's been guiding me through starting using silver fluoride through public health in Rockhampton area, and I'm loving it so far, and really enjoying seeing the results and just the atraumatic treatment with the children. That I'm also keen when I'm back in adult scope to be using it on adults as well. And this is a great example. Thank you so much.
It's a pleasure, Kate, a pleasure. But it is truly quite remarkable. I mean, when one thinks of in this case, the alternatives, the poor chap would have been, well, he would have been having pureed food, quite frankly, if those root stubs hadn't been kept. So it was a positive result all around.
This is your chance to ask Graham any questions you have about silver fluoride. So it doesn't necessarily have to be now about this case. Whilst you've got two ears that are ready to listen, Graham, to the questions, we may as well, if you've got any questions at all that you haven't asked me, or that you'd be burning to ask Graham, ask away now.
I just, if you don't mind me asking, now, as I say, I only just started using it. So if I have a class 2 cavity and it's
Yep.
a food trap, I guess, I can just check that it's arrested well and then go back and restore that tooth. Is there any concern if you have a very uncooperative child with a food trap that you leave it open?
No, well. I mean, if it's a food trap, you would have seen a food trap initially. If you look down at the gingival tissues, it was the patient in question. Was he or she complaining when she ate, meat or chicken or anything like that? Because that's that's a classical sign of food impaction. And quite often, that's often misinterpreted as some form of chronic alveolar abscess. But if there was no food impaction there initially, and with primary teeth, it's much different to the permanent dentition. As long as there is a contact at or above the gingival margin. Now, with permanent teeth, you've got to have a proper contact area, and that's well above the gingival margin. But as long as there's some contact at the gingival margin or above, food impaction is usually not a problem. But if food impaction was a problem from the word go, one has two options to get maybe the patient on side, and then do some, it's like the old Inger's technique, where you actually do a bit of a slice preparation so the food literally drops away. Yeah, I mean, they're the two options. So either as soon as possible put in a glass ion on the cement, or if you have the option of opening up so that no food gets caught, you can follow that one. By the way, to prevent food impaction, I'm just going, we used to have a rule of thumb. I think if there was a space of about 1 millimetre or so between, let's say, the lower first primary mole and the second primary mole at the level of the gingival margin. If the space was about 1 millimetre or more, usually, and I say usually, if you get to that, food impaction wasn't a problem.
Right. Okay, there's a couple of, sorry.
Thank you. I was just going to say thank you. Thank you very much.
Okay.
Okay.
There's a couple of questions that have come in here, Graham, too. You in that original case, how were you able to isolate the teeth in that circumstance?
It was simply because the patient had so little saliva, it wasn't a major problem. And just keeping the tongue away with the mirror was a gentle drying of the tooth surface, holding the tongue away gently with a mirror, so that that worked. That worked. But if the patient had a normal salivary flow, well, it would have been a bit more of a challenge.
Mm-hmm.
So you virtually did it almost a dry mouth.
Okay, and then somebody's asked, they said it was a great case, but can you tell us the resources to access for regarding use in adults? That would be Alan Deutsch's book too.
Yes, yeah. Alan has written a handbook on his experiences at Montefiore, and it is available through Dental Outlook, or the Dental Outlook website, www.dentaloutlook.com.au.
I might put a link in the a link to how people can get access to that. I'll put that in the group page.
Okay.
Okay. And also they wanted to know what journal the case study was in. You know, the one.
Special care dentist.
Okay. Everyone says it was a great case study, and thank you. All righty. We've probably got 5 more minutes, so if anyone's got any questions at all, I will be putting this up as a recording after I've done some serious editing.
Good on you, Kath.
Golly Mose.
Kath, I just wanted to mention I had success with the Equia Fort, and my principal dental officer has agreed to get that in.
Wonderful, wonderful. You'll really enjoy using it, Kate. It's a great product, and I find it particularly good to put with silver fluorides because of it's opaque, but it's also extremely strong, and it's really good for class 2s. When you were asking that question before about the the food impaction, I have done a lot of what Graham was talking about is the Inga technique, which I nicknamed the cup and saucer technique. And basically, when you've got a cup-shaped lesion that is trapping food, then I actually take the edges off, which is what you do in the Inga technique, and you sort of just make that really cleansable. So food just basically is brushed in and out. You tend not to lose very much space at all as far as the 5 drifting, because you're not taking a lot out, and to be honest, that space was already created by the caries lesion anyway. So and then I get them to floss and to brush well. Sometimes I'll fashion a little end tuft brush and give them a special brush to clean down there, and that works really, really well. And then of course you don't get any, because you've got such good saliva flow going through there, and it's being well brushed, they just don't have any problems with it. So you can
That's great. Kathy, what did you say? Inga technique, did you?
Yeah, it's INGER, I believe, Graham, isn't it?
That's right, yes.
You don't see very much written about it. It's a very old technique. So
very good.
Yeah.
Okay. That's great. Thank you.
Well, we used to use it a lot in the olden days, probably because Graham taught us. And there was we didn't have GICs back then. You got to remember, no GICs, certainly no, stainless steel crowns. So we came up with these kind of things, but they really worked, and they worked well.
Yeah. Okay, there's another question, so I'll mute myself. There's another question.
Righty-ho. Now there's a question coming up here. Can we apply on deep caries into pulp without clinical symptoms.
Into a pulp.
It says,
Are we talking about,
caries
are we
into
talking
the
about,
pulp.
are we talking about primary teeth?
Not sure. I'd imagine so. Okay. We've only got a few minutes left. All right.
Okay.
So
Look, can I just,
as though you're talking about primary teeth.
okay, if in primary teeth, the basic rule of thumb is that now if you've got a deep lesion, a good bite wing radiograph is invaluable, and yeah, absolutely invaluable. And if you've got 0.5 millimetre or more of radiographically sound dentine between the base of the lesion and the pulp, you're usually A-OK. And why this works with primary teeth, because the actual clinical depth of lesions, occlusal and proximal surface lesions in primary teeth is very, very close to the clinical depth. Now, this doesn't happen with permanent teeth, but it does happen with primary teeth. And we think the reason being is that the enamel is so much thinner in primary teeth. Now, can I just throw in with adult teeth? If going back just a while back, and this was with silver diamond fluoride, operators were using the ART technique, and this was, I think, in Cambodia, and they're working on children there, excavating all the caries and putting on silver diamond fluoride, and the kids were taking off out of the chair. Now, if one is going to use a silver fluoride preparation with a high concentration of silver fluoride, etc., one, and I'm talking about permanent teeth here, one has got to have a layer of caries remaining, because otherwise the application of the SDF or the silver fluoride causes a massive osmotic gradient. If you can go back to your chemistry, it causes a movement of fluid out through the dentinal tubules, at which, if this happens, of course, you get a very, very untoward, you get a painful response. So with permanent teeth, if you're using silver diamond fluoride, if you're using silver fluoride, make sure that there's a layer of caries left behind.
One question, if there is gingival overgrowth on deciduous, can you still apply CSDS?
Yes.
Yeah, I would say, yeah, that's what my answer would be too.
Yeah.
Okay, folks, we've got to wrap this up. Thank you so much for joining us today. This will be up on the Facebook page, and then you can share that around. And hopefully you've gained some really great insight information. And thank you, Graham, for joining us. And
Pleasure.
For your first Zoom appearance ever. We'll have this marked out. Okay. Thanks, heaps.
Thank you.
Okay. Bye,
Cheers.
folks. Bye.
Thank you. Bye.